Next slide, please. So for those of you who are just jumping into this series, we started back in February looking at prevention and management of patients with chronic conditions. And today we're going to take a look at diabetes management. So next slide, please. So many of you may know, but if you're new to us, the IPRO QIN-QIO is a partnership between IPRO Health-Centric Advisors and Clarent. And together we cover 11 states plus DC as the Medicare Quality Improvement Organization contractor. And we work to ensure high quality healthcare for about 20% of the nation's Medicare fee-for-service beneficiaries. Next slide, please. So we are recording today's session, as you saw, and we really encourage participation in chat. So please introduce yourself, let us know if you have questions or if there's something that's really going well for you and you want to share that. We'd love to hear that too. It really helps others who are on the call to hear what you're doing too in chat. So, we definitely encourage that and thank you in advance. All right, next slide. So as I mentioned, we're going through a couple of different things in this series, and today we're going to be looking at diabetes, and future sessions, as you can see, will be on cardiac rehab and the role of nutrition in May. Next slide, please. So learning objectives for today, we're going to really be focusing on evidence-based strategies and tools for improving diabetes outcomes for patients, different things like the diabetes self-management education and a variety of other approaches, and of course, looking at disparities and social determinants of health as well. Next slide. So without further ado, I'm going to introduce our great team that we have today to talk about a lot of interesting things. So I'm excited to hear what they have to say. We have Janet Jones from Clarent, who's a project manager, and she is also a nutritionist and diabetes educator. We have Angela Diggs, who's program manager and chronic disease team lead at Clarent, and also Laura Benzel, who's our health equity lead. So thank you all. And with that, I'm going to turn it over to you, Angie.
Thank you, Laura. Good afternoon, everyone. We'd like to start today's session off with a thought question. As healthcare providers, I'd like you to picture the community where you work and serve. Do you know what the percentage of those patients are that have a diagnosis of diabetes? Knowing the percentage of patients that have diabetes in your organization can have a major impact when making decisions in the various aspects of their management. For those aspiring to improve their quality metrics, setting quality goals for patients with diabetes can be a start towards improvement in quality of care and outcomes for both your organization and the population that you serve. Next slide, please. Now we'd like to take a look at the diabetes snapshot. More than 37 million people in the United States have diabetes, and 1 in 5 of them don't know they have it. There are approximately 28.7 million people that are diagnosed with diabetes, and about 28.5 million of those are adults. In addition, 23% are undiagnosed, and over 1/3 of the adults have prediabetes. 8 out of 10 don't know that they are pre-diabetic. A few other facts. Diabetes is the 7th leading cause of death in the United States, and this may even be underreported. Type 2 diabetes accounts for approximately 90 to 95% of all diagnosed cases of diabetes. Type 1 diabetes accounts for approximately 5 to 10% of the total number diagnosed with diabetes. And in the last 20 years, the number of adults that are diagnosed with diabetes has more than doubled as the American population has aged and become more overweight or obese. Next slide, please, Janet.
Good afternoon, everyone. So we've looked at the U.S. Snapshot. Now let's look at the IPRO QIN-QIO region. As stated earlier, IPRO covers 11 states and the District of Columbia, and we provide hospitals, state, and community Medicare fee-for-service data reports to organizations that work with us. This slide shows the 10 readmission diagnosis categories for our combined region. The graph doesn't show readmission rates, but does show how prevalent certain diagnoses occur for readmitted patients. You can see that that diabetes was the highest readmitter for the 1-year period shown, and that the prevalence of diabetes is 38.2%, which means that more than a third of all beneficiaries who were readmitted had a diagnosis of diabetes. Finally, when you look at the other diagnosis categories like congestive heart failure and CKD, you can see they are almost as high as diabetes. These diseases are comorbidities and are related, I like to call them cousins, to diabetes, and can be brought on in some instances because of poor glycemic control or management of diabetes. Next slide, please. This slide shows us the readmission data by quarter for 11 states and the District of Columbia from 2020 to the third quarter of 2022. The readmission rate to hospitals within our region for those with diabetes remained pretty steady at around 23%, even during COVID. This makes a case for continuing to work within our communities to manage these patients effectively, which can make a huge difference in their quality of life. Next slide, please. Angie.
Thanks, Janet. And now we have another question for you to consider. When you're assessing patients with diabetes, have you considered asking them what having diabetes means to them? If your answer is yes, please use your thumbs up reaction. Asking this simple question can give providers a better understanding of, one, where your patients are, do they understand what having diabetes actually means, which can also give you insight to their health literacy level. And two, assessing the needs of your patient gives you the ability to meet your patients wherever they are in managing their disease. Just looking at your patients may not always be what it appears. We cannot assume anything. I'm sure we all have a story of a patient that we assumed understood, but later found out they actually did not. For example, I was part of a multidisciplinary diabetes team. And we had a patient who had extremely high A1C levels. And as a part of the team, the endocrinologist continued to increase her insulin, attempting to get her A1C levels lowered. But in fact, every time she returned, her A1C or her blood sugars were actually higher. At this point, the team took into consideration something had to be wrong. Something just was not going right. So we asked the patient to come in and show us how she was actually taking her insulin. And at that point, we had already made the switch from insulin vials and syringes, considering that she may have been underdosing her actual insulin doses, and that was why it wasn't working. But until she was on the pen at this point, and we just weren't sure what the problem was, why she continued to increase. So when she came in, we asked her to show us exactly how she was taking her insulin doses. In fact, she thought she was injecting insulin, but she, however, was failing to take the top off the insulin pen. Therefore, she was not getting any insulin at all. It's things like this is why we cannot emphasize enough how important it is to assess the needs of your patients with simple questions and taking the time to listen. Patient-centered care is one of the latest updates recommended by the American Diabetes Association, which we'll talk more about in a few more slides. Next slide, please. So let's take a moment to discuss getting back to basics and managing your patients with diabetes. As a result of the pandemic, when routine office visits were no longer the norm, many patients may have gotten off track with their routine lab work as things are getting back to normal, this is a good time to get everyone back to routine care management basics. As you already know, patients with diabetes should see their providers at least 2 times a year. At least once a year, they should have an eye exam, a foot exam, a dental exam by a medical professional. Hemoglobin A1C should be done at least twice a year and can be done every 3 months if blood glucose control is not within target ranges, according to the 2023 ADA standards of care. We know glucose monitoring and medication management should not be a cookie cutter approach, but based on each patient's individual needs. Estimated glomerular rate should be done at least once a year. Next slide, please. As we're getting back to basics, we also recognize that managing patients with diabetes often requires a team. Therefore, you may need to consider referring your patients to one or more additional providers. Patients with diabetes often have a lot to manage. You can help them by encouraging them to take one step at a time. That's why it's important that they have a healthcare team to help them set goals and make treatment plans that they can stick with. When assessing your patient's understanding of diabetes, this may help you in determining which team member services are needed to help your patients successfully manage their diabetes. The link for this resource is located at the bottom of this slide and available in our IPRO Resource library. The link to the library is also in the resources. Next slide, please. Setting goals with your patient is another step in successful management. Goals can be small to ensure that patients don't become overwhelmed and encourage successful outcomes. Once goals have been established, it's important that both the patient and the provider revisit the status of these goals routinely. Goals can include exercise, how often they should monitor the blood glucose, nutrition goals, and maintaining follow-up visits. If your patient doesn't understand what the numbers mean, then goal setting may have less value to them as a patient. Many patients have no idea what their goals are or why they are important to their long-term health as a person with diabetes. Using the ABCs tool can be a helpful method in increasing patient knowledge and effective goal setting. Reviewing your patient's knowledge of their numbers and where they are in regards to the current recommended target helps with establishing realistic goals, which will vary based on the needs of each patient. We realize that weight is not a part of the ABCs. However, for patients with type 2 diabetes, the ADA Standards of Care recommends a 10% or greater, 10% or a loss of 10% or greater of their weight. This can make a huge difference in blood glucose control and blood pressure. Next slide, please, Janet.
Thank you. So we talked about the ABCs as a tool to encourage patient success. The tools we develop and the information we share with patients and community members are based on the ADA Standards of Care in Diabetes. The most recent update was done January of this year. So let's take a brief look at a few of the updates found in the summary of revisions. One of the most important additions to the standards of care is that ADA is now recommending more language that encourages person-first, inclusive language that empowers people with diabetes and recognizes the individual as the center of diabetes care. Next slide, please. There are 17 topic areas in the standard of care, and many of them have some type of update. So it's impossible for us to cover all of them today. So we picked a few to briefly cover, and I'd like to thank my coworker, Ingrid Garcia, who pulled this table together for today's talk. Section 6 reminds us to set individualized glycemic goals with patients during visits. This is much more likely to improve patient outcomes. Target ranges can be set based on the patient's age, their health, type of diabetes they have. Setting goals with them is also in line with the more patient-centered approach that ADA recommends. Setting personal targets for each patient and including them in the discussion when possible generally results in better outcomes. Section 8 discusses both healthy weight management. We know obesity is a chronic disease, but individuals that are diabetes or overweight or obese, and many may benefit from modest or larger sustained weight losses, as Angie mentioned, greater than 10%. They also encourage that when choosing glucose lowering medications for people with type 2 diabetes, and they are overweight or obese, that you consider the medication's effect on weight. So choosing a medication that will contribute to weight loss in addition to glycemic control is very helpful. Section 10 talks about hypertension and cardiovascular risk management. Blood pressure treatment goals in individuals with diabetes was revised to target a blood pressure of less than 130/80. I know for years when I practiced, it was always 130 or 80. I'm sorry, 130/80. And for most patients, they see that and it tends to creep up. So now it's finally 130/80 or less. They also ask us to consider pharmacological treatment in people with diabetes and a confirmed blood pressure over the 130/80 mark. Section 11 talks about chronic disease and risk management, and the recommendations have been changed to reorder the priority aimed at preventing and slowing progression of CKD. When you see kidney function lab work worsening, it's better to make changes earlier than later. Changing medications and referrals to a nephrologist at the onset of changes helps, and it's dependent on lab work like the estimated glomerular filtration rate and the urinary albumin and the creatinine levels. As they start to creep up, it's better to do the work, refer patients to a nephrologist or change medications early on. We encourage you to review the updated 2023 standards of care for yourself. As I said, it's just too much for us to cover during this talk. Now let's move into the best practices and evidence-based interventions. Next slide, please. Angie.
Thank you. We know that technology continues to rapidly change. You've probably heard the latest on artificial intelligence, both the good and the bad. There are ways that technology can be used to better treat patients and help them manage their medication conditions. Digital technology is particularly useful for self-management of diabetes. There are automated insulin delivery systems, glucose monitoring, blood glucose monitoring, or continuous glucose monitoring devices, infusion sets to name a few. The data from these devices can be loaded into the EHR, making it a more efficient way for providers to stay connected to their patients. Remote patient monitoring Remote patient monitoring helps providers stay informed of patients' progress and control. This also assists you to understand how medications are working and allows real-time patient management. Electronic order sets embedded in EHRs can serve as clinical decision support tools to help physicians identify evidence-based treatment protocols. Health information exchange allows providers and patients to access and securely share the patient's medical information electronically. Providers can access critical medical history and things such as lab test results, medications, and allergy history, no matter where patients received care. This enables patient-centered care that is better coordinated, avoids duplication of treatments, medication errors, more accurate diagnoses, and reduces unnecessary readmissions. This in turn can reduce overall healthcare costs. Next slide, please. Now let's look at a few best practice recommendations. MedStar Shaw Medical Group, one of our recruited practices in the state of Maryland, shared what they found to be an extremely successful best practice. They utilized their EHR system to pull all of their patients having chronic disease diagnoses, which obviously includes patients diagnosed with diabetes. They then went on to verify those who had missed appointments, had abnormal or missing labs, elevated blood pressures, cholesterol, or glucose levels. Once the data was retrieved, they moved forward with contacting patients to get them scheduled for necessary appointments, provide lab orders and referrals to needed services. The practice reports this was extremely successful with great outcomes in getting patients back on track following the delays and missed appointments caused by the pandemic. It was so successful that they continued to use this process, now for more than a year, and have incorporated utilizing this best practice to ensure patients are up to date with additional services like mammograms and colonoscopies. Remember to use your state HIE as an additional resource to determine any hospitalizations, ED visits, prescriptions, and lab work that may have been done since your last visit with the patient, and incorporate that information into your patient's assessment. Finally, utilizing both your EHR and HIE can help you to determine focus areas and develop goals that can improve quality metrics for payment. Next slide, please. Remote patient monitoring. Remote patient monitoring utilizes technology that enables monitoring of patients outside of conventional clinical settings. When managing patients with diabetes, providers can track and manage things like blood pressure, blood glucose, to name a few, depending on the system that you choose, as well as other symptoms and conditions that you may choose to track on your patients. Utilizing remote patient monitoring allows providers to make real-time changes in medication and care between office visits if needed versus waiting until the next office visit. Next slide, please. A continuous glucose monitor is a device that continually monitors blood glucose. It gives real-time updates through a sensor that is inserted under the skin. It can alert patients if glucose levels go too low or too high. Patients monitoring glucose levels through CGM can reduce or eliminate the need for finger stick glucose testing. And this can provide richer information about glycemic levels and if they are hyper or hypoglycemic, or if they have extreme glucose variability. CGMs require a prescription written by a medical provider and are covered by most private insurances and Medicare if patient eligibility requirements are met. CGM training for patients new to the device must be provided by diabetes care and education specialists that have been trained to teach patients how to insert the sensors and how to use the device, as well as educate them on the frequency of changing the sensor. Next slide, please, Janet.
Thanks, Angie. The IPRO Quick Guide pictured here gives guidance to when patients should be referred for diabetes education and self-management programs. The guide was created from the ADA standards as well, and it states referrals can be made at initial diagnosis, during their annual assessments, when new complications have developed, or if there are changes in glycemic control, or if there's disease progression. Also, upon transitions of care, especially if changes have been made to their previous routine while they were in the hospital or whatever facility they were in. Certified diabetes care and education specialists, it's a lot to say, but they're now called CDCES. Years ago, we were just CDEs, but now we're CDCESs, should lead these programs and can be either a registered nurse, a registered dietitian nutritionist, a pharmacist, a nurse practitioner, a physician assistant, or a doctor. Remember to encourage your patients to take advantage of these professional services for better outcomes in their self-management. Also remind them that diabetes education is a continuous process and not just one and done. The recommendations for starting or referring patients to M&T are quite similar to referring patients to diabetes self-management programs. We've been sharing links with you in the chat, and they will also be in the references when you receive the slide set. Next slide, please. So referring patients for M&T is very important. According to ADA, medical nutrition therapy is a key component of diabetes education and management and is defined as nutrition-based treatment provided by a registered dietitian nutritionist, and from here on, I'll refer to them as RDNs. M&T includes a nutrition diagnosis as well as therapeutic counseling services to help manage diabetes from the RDN. Studies have documented an association between M&T delivered by an RDN and A1C decreases for people with type 1 diabetes as much as 0.3 to 1%, and for those with type 2 diabetes as much as 0.5 to 2%. Managing what we eat is one of the keys to managing blood sugar. Every patient wants to know, what can I eat? Knowing what to eat, how much, and how often is important for them to understand. Emphasize with your patients that though there will be changes, the RDN will help them understand why changes are needed, and how what they eat affects their glucose control. Many insurances cover M&T services, but patients will require a written referral from a medical provider. The M&T must be provided by an RDN to be covered by most health insurances. Medicare Part B covers M&T for diabetes and kidney disease. Patients with private insurance should be encouraged to check with their individual plan for coverage details before seeing the RDN. Next slide, please. Now let's move into therapeutic inertia. This is a different type of best practice that needs to be addressed. According to the American Diabetes Association, therapeutic inertia is a lack of timely adjustment to therapy when a patient's treatment goals are not met. In diabetes care, it means being slow to add or change the care plan if a patient's A1C remains high. Changes in medications, frequency in health checks, or follow-up visits, diabetes education, nutrition therapy, exercise, and emotional support can all be a part of the changes to the care plan. Though patients are often afraid to make changes, educating them as to why, and if possible, making them a part of the decision-making process may help. ADA's focus is on improving clinicians' understanding of and adherence to ADA standards of medical care in diabetes, with a focus on appropriate and timely treatment intensification, which is the best practice. Next slide, please. So to avoid therapeutic inertia, ADA recommends improving your team's understanding of inertia and how it impacts the overall health of people with diabetes. Second is patient goal setting, keeping in mind that you are the coach and your patient is a part of the team, establishing a plan for the best in your patient's care. So establishing goals, but most importantly, following up on those goals with the patient at as many visits as possible is key. Next slide, please. Other protocols that you can initiate to eliminate therapeutic inertia include scheduling diabetes-only visits, where you and your patients can focus solely on diabetes, schedule follow-ups based on the patient's A1C level. If the A1C is greater than 9, then 6 to 8 weeks. If the A1C is between 7 to 8.9, then every 2 to 3 months. And if the A1C is less than 7 or at target, then 3 to 6 months would be recommended. We've already discussed when to refer patients to self-management education, but make sure that all staff knows these guidelines and assists you in the referral process. Make it a routine protocol to check patients for barriers by using screening tools for depression and social determinants of health. Remember, changes can occur at any time, so it is important to do this often, especially if there are several months between visits. Things like the loss of a job or a loved one, changes of weight, changes in health status, or changes in the disease process can be stressors and can change glucose control and should set off that internal alarm to do a deeper dive with patients if needed. Laura, I'll hand it over to you.
Hi, everyone. Thanks, Janet.
Laura,
I'm
I'll hand it
Laura
over to you.
Benzel. Hi, this is Laura. Can you hear me? Okay, great. This is Laura Benzel, and I'm the Health Equity Lead for IPRO. I'm happy to be here today to discuss ways that you can promote health equity in diabetes care. So I know we talk about social determinants of health a lot. It's a much discussed topic, and that's because we have a much better understanding of the impact of social determinants of health on health and well-being. So we're still challenged with the best ways to address them. So it is something that we think is important to discuss. And hopefully some of the information I share today will be helpful. Next slide, please. So when I was doing some research on statistics around diabetes disparities, I came across this statistic, which I thought was interesting. There is some good news, after 2 decades of continual increases in the incidence of newly diagnosed cases of diabetes in the United States, according to the CDC, we've actually are now seeing a decrease from 2009 to 2019. This is their data. So we've gone from 9.3 per 1,000 adults to 5.9. But as Angie mentioned earlier, there's still a lot of people that have diabetes, and it is a complicated disease to manage. So it's so important that we have educational events like today, because we also find that many patients find it difficult to manage as well. Next slide, please. So the not so good news is that there are still persistent disparities in diabetes. So for example, some information I'm sharing here on this slide is that Black adults are 60% more likely to be diagnosed with diabetes than their white counterparts. 2019, Black adults were 2.5 times more likely to have a hospital admission related to diabetes. And you can see some of the other racial and ethnic minorities have a higher incidence of diabetes compared to their white counterparts. And the other interesting thing is that COVID-19, 4 in 10 adults who died from COVID had diabetes. And because COVID had a disproportionate impact on racial and ethnic minorities, they of course, bear the brunt of those that mortality. So just some interesting statistics to show that the disparities are still happening. And so hopefully we can do some things to reduce them. Next slide, please. So the social determinants of health and how they impact diabetes. So, research has proven obviously that social determinants of health can have a significant impact on health outcomes and quality of life, as I mentioned earlier. And I'm sure you've heard the statistics, non-medical determinants of health are believed to account for 60 to 80% of health outcomes, and 40% are related to socioeconomic factors. It's a little despairing to note that there's an estimated 15-year life expectancy gap between advantaged and disadvantaged individuals. So disadvantaged individuals who have higher health-related social needs actually will live 15 years less than those who don't have those needs. So it's really disheartening, and that's why we're discussing this topic. So when there is a lack of awareness of these issues faced by patients and an inability to address them, it can have obviously adverse effects on patient outcomes. Next slide, please. So Janet already talked about the ADA standards of care. I'd like to just touch on some information from the standards of care about social determinants of health. So, as Janet mentioned, comprehensive information is released yearly as the diabetes standards of care change, and they're intended to provide clinicians and other interested parties with components of diabetes care, treatment goals, and tools to evaluate the quality of care. So the 2022 standards of care included level A evidence recommending that clinicians assess for several health-related social needs. Examples are food insecurity, housing instability, financial barriers, and social community support. So recommendations for social determinants of health were then expanded in the 2023 standards of care. These include considering social determinants of health in the design and delivery of diabetes self-management education and support, in glucose lowering management, in medication, and psychosocial screening protocols. So we're seeing a more emphasis on considering social determinants of health in the diabetes care. Next slide, please. So I just mentioned food insecurity as one of those social determinants of health. It's a big issue. It's a risk factor for diabetes and ineffective diabetes management. So I wanted to share some resources for you to learn about food insecurity in your state that may be helpful so that you can target diabetes interventions for patients who may be experiencing food insecurity. So this is a screenshot of an interactive mapping tool from Feeding America, and you can see the link on the bottom of the slide there. You can view food insecurity information at the state level. So this is a screenshot of Maryland because I live in Maryland, and the map shows the rate of food insecurity by county. It also shows the number of people in Maryland that are food insecure. It's about 543,000 with a rate of 9%. And also it includes information about eligibility for SNAP and other food program in the state. Next slide, please. So this is another screenshot with further information on food insecurity in Maryland. So as I mentioned, the rate is 9%. More than 543,000 residents are food insecure. It also shows, again, eligibility for SNAP. And that's important because obviously that's going to provide support to folks that are insecure or food insecure. However, the percentage that don't have eligibility for those programs is also especially important because obviously they're not going to have that support. So these data can help formulate a response to addressing food insecurity. Next slide, please. So this is actually a drill down to the county level. This is a screenshot of Dorchester County, which is in Maryland. And all of the data, by the way, is from 2020. So Feeding America uses a lot of different data sources for these statistics, but mostly comes from the Food and Drug Administration. Next slide, please. So the same data that we view at the state level, again, you could view at the county level, and this is Dorchester County information. So it's really helpful because you can drill down. It's an interactive map. As you slide your cursor over the map, it'll give you, it'll pop up information for each county. So it's easy to use, and it provides some additional information that I'm not including on the slides here around disparities that you may find helpful. Next slide, please. So another tool that I wanted to bring to your attention is the CMS Office of Minority Health Mapping Medicare Disparities tool. This is another interactive map to identify areas of disparities between subgroups of Medicare enrollees, and you can look at health outcomes, utilization, and spending. So this is a map that I created showing the prevalence of diabetes for Medicare beneficiaries. I chose the age group 65 to 74. You can choose a different age group. I am looking at both male and female, but you can stratify by one gender over another. And I'm also looking at all racial and ethnic groups on this map. But again, you can stratify by different racial groups and ethnicity. So it's a nice tool because it allows you to drill down with those health equity elements. You can stratify the data to understand and investigate geographic and racial and ethnic differences for 60 specific chronic conditions, emergency department utilization, readmission rates, mortality, preventable hospitalizations, and preventive services. So it's a really nice tool. And the data is from October 2022. That's the last time that CMS updated the data. So it's fairly recent data. Next slide, please. You can also view county level social determinants of health data on the CMS tool. It includes income, English proficiency, race, ethnicity, insurance coverage, insurance coverage type, and unemployment information. So again, this is information in Maryland for Baltimore County. So I split the graphic in two just so I could fit it on the screen. So this is one half of the graphic. And if I could go to the next slide, please. This is the second half. So it's really valuable information, again, because we're putting such an emphasis on social determinants of health. This, again, can help you to evaluate what your patients may be experiencing in your geographic area. Next slide, please. So this brings me to Z codes, which, CMS is really asking us to encourage the use of Z codes to record the social needs of patients, and they're recorded in the electronic medical record. So a subset of ICD-10 Z codes capture encounters related to social risk factors. So the 10 categories of Z codes for those social needs are on the table here on the screen. According to CMS, Z codes are important because they can be used to identify individual social risk factors and their unmet needs. It can inform healthcare services follow-up and discharge planning, so important for that information. Z codes can help trigger referrals to social services that will meet the individual's needs, and also allow you to track referrals between providers and social service organizations or community-based organizations. So adoption of Z codes has been slow, according to the CMS Office of Minority Health. They released a report that shows that providers use Z codes for only about 1.6% of Medicare fee-for-service beneficiaries. So that was in 2019. Hopefully, when they release another report, we'll have seen that that has increased. So QIOs are working with CMS to promote the use of Z codes. And they wanted us to acknowledge then, and they acknowledge that Z codes, using Z codes to record social needs, doesn't always result in direct reimbursement. So they acknowledge that. However, social determinants of health data will be associated with CMS reimbursement in the future. So putting a process in place now can facilitate a seamless transition. And obviously other providers are reimbursing for social determinants of health. Next slide, please. So interestingly, IPRO ran a state snapshot of Z code uses for each state and DC. As Angie and Janet mentioned, we support 11 states and DC, so we ran a report. And this includes, you can see here that there are the most used Z codes across those 11 states and the District of Columbia. And the number one Z code used, 60.2, are problems related to living alone. It was reported more than any other Z code in our area that we support. The second most used Z code was disappearance of a family member. Homelessness was next, and unemployment was fourth. So these are the Z codes and the health-related social needs that providers in our area have reported the most. Obviously, it could be different for your specific area, but if you are a provider, using Z codes can be vitally important when treating patients, such as having a better understanding of why a patient, for example, may not be adherent with their treatment protocols. Lots of times we think they're just not listening to us, but it could be some social need that's affecting their ability to effectively manage their chronic conditions, including diabetes. Next slide, please. I'm now going to turn it over to my colleagues. Thank you.
Thank you, Laura. Thank you for sharing the many effects of social determinants of health when managing diabetes and ways to promote health equity in diabetes care. Here are a few strategies to consider. I'm sorry, I didn't ask them to advance the slide. Thank you. Here are a few strategies to consider for addressing social determinants of health. As a standard routine, have patients to complete a simple social determinants of health screening tool prior to being seen by their provider when possible. Utilizing this tool will alert you to possible social determinants of health will alert you to possible social determinants of health, which will allow the provider to address any areas of concern and provide necessary resources and referrals. Provide patient-centered care, focusing on patient engagement and communication. Take a moment to ensure that your patient understands what they're supposed to do and why they need to do it. Improving health literacy is especially important when managing a chronic disease such as diabetes. It is a complex condition to manage, so things like using simple language when explaining diabetes. Try to avoid using medical terminology patients don't understand. Asking open-ended questions, giving patients a chance to answer. Or using the teach-back method, allowing the patient to repeat back to you what they need to do. This can be helpful in assessing and determining the understanding for your patients. We would be remiss if we didn't discuss the elephant in the room when addressing patients with diabetes. Sometimes patients are labeled as adherent or non-adherent, or a term often used in the past but is no longer acceptable, is compliant or non-compliant. We cannot stress enough how important it is to listen to your patient. Consider that they may be experiencing one or more social risk factors that may impede their ability to follow their treatment protocol. It could be something as small as them simply not understanding, or something as big as them not knowing where they will be living the next week, that being a bigger concern to them at the moment. The majority of time, the patient is not just refusing to follow recommended medical care. There is a reason or a social factor that they are not able to. When patients are unable to meet recommendations that you feel are best for them, sometimes it's best to try to meet patients where they are by setting smaller, more attainable goals for them to help encourage them to strive towards the larger goal. Next slide, please. As we mentioned earlier, managing patients with diabetes requires a team. We would like to share some additional community-based programs and services that benefit patients who are managing diabetes. DPP, the Medicare National Diabetes Prevention Program, is a partnership of public and private organizations working to prevent or delay type 2 diabetes. The partners work to make it easier for people with prediabetes or at risk for type 2 diabetes to participate in evidence-based, affordable, and high-quality lifestyle change programs to reduce their risk of type 2 diabetes and improve their overall health. DSMES, Diabetes Self-Management Education Support, is an evidence-based program for people with diabetes to gain the knowledge and skills to make behavior changes and better control their diabetes and related conditions. This evidence-based practice accounts for the needs, goals, and life experiences of the participant. These programs can be offered in several different languages, as well as resources and materials. Most classes are currently offered both virtually and in person at various community-based locations to include hospitals, community centers, insurance company programs, along with community organizations like your local health department. Next slide, please. We would like to thank you for attending today. We have included some extra resources for you to review, including a new smoking cessation resource to increase services and reimbursement. We recognize the complexity of managing patients with diabetes, and today's discussion only covers a portion of what managing patients with diabetes requires. We look forward to having more discussions surrounding management of this disease process. At this time, please feel free to ask questions. Laura, do we have any questions in chat?
Thank you so much, Angie, Janet, and Laura for such a great presentation. A lot of great information shared today. So we don't have any questions yet. So we do encourage folks that we have time. If you have questions or comments, please feel free to jump in and let us know. And Patricia, thank you. She's a great presentation and a lot of resources shared. Yes, thank you, Patricia. So here are some additional resources while you're thinking maybe of potential questions you want to ask our speakers today. So I think we had mentioned the diabetes specialty team fact sheet earlier, and then we also have what we call a links portfolio package. Links is local interactive network of knowledge sharers, and that basically just means connecting with a lot of the community-based organizations that are in communities that we work in. And it's really it's just like a fact sheet. Someone's really new to diabetes, or if you're looking to just really educate early and do diabetes prevention. And there's also a PowerPoint presentation that can be adapted to meet the needs of your community. And then there's the A1C fact sheet as well. And we did have a question from Walter in Vermont. Do we have Z codes by street for Vermont? And no, unfortunately, our Z code data is very just sort of statewide. So it sort of gives you all the different Z codes that were identified sort of by, starting with the top code and then kind of working down. So it's not really drilled down by specific community or state. But we do have, and this may be of interest to some people on the call, is we have community reports for care transitions that, are broken down by, groups of zip codes in your state. So reach out to us if you're interested in more of the data that we have available. And so does anyone else have anything they wanted to add in terms of the data that we have?
I will encourage everyone, if you wherever you live, to use the data. It is a little older by about 3 months or so, but it's very useful and sometimes giving you the broader picture of the area you work in. And it's here, it's available to you. So please make use of it, as Laura said.
Thanks, Janet. All right, well, next slide, please. So as I promised, we do have our contact information here, and the recording and the slides from today will be on our event page for this series. And once we get that all squared away, so please be sure to circle back if you want to share with colleagues, or want to maybe catch up on previous sessions. We will be having everything on that page. Next slide, please. Oh, and here's sort of, as we have our subject matter experts. Next slide, please. And as we mentioned earlier, so we're going to be doing a sort of a recap on some of the chronic kidney disease and diabetes topics and resources that we've covered so far in 2 weeks. So, you're welcome to join us then. It'll just be a quick half hour. And then next month, we'll be looking at how to increase referrals and participation in cardiac rehab, and then a little bit more of a deeper dive in the role of nutrition. Next slide, please. So your feedback is really important to us. Let us know how we're doing, and if there's something that would be really helpful for you for a future session, please let us know, and we'll be sending out that brief evaluation in our follow-up email. Next slide. So here's our website. You can access all of our upcoming events and our resource library by going to this homepage, and we hope that you do that and connect with us there. Next slide, please. So if you don't have any questions right now, we will be wrapping up, giving you a couple minutes back to your day. Thank you so much for joining us. We know you have a lot of conflicting priorities, and we so appreciate you taking the time today, and thank you for your partnership.